I don't see the host, but that's all right. I'll go ahead and get started. There we go. So today, it's going to be a review and update on what we're doing within Marshfield Clinic on the occupational health front. We're going to take a look at workman compensation, what we've done. Chad has been here for closing in on a year. I've been here for 18 months. And oh wait, I got people in. Hold on one second. There we go. Okay, sorry about that. And you want to take the rights back, Karen, because when people join, it's popping up. And I'm a little bit of a squirrel. Oh.
So Dr. Conrath, you have to give them back to me.
Giving them back right now. I apologize for being a little bit squirrel. I'll look over every time that pops up.
Well, I'll take care of it. You just continue on with your discussion.
Yeah. So I've been here for 18 months. Chad's closing in on a year, and we just want to give you an update on some of the progress we've made with the workman's compensation. I want to talk a little bit about an industrial athlete program that has been reinvigorated. And third, we want to touch on what we have in the COVID offerings. We want to keep the COVID talk a little bit lower, not as much, because I believe a lot of you have heard that previously. So for those that don't know, I'm Dr. Corey Cronrath. I've lived a double life. There on the left-hand side of the screen, I was an Army physician for, some time before coming to Marshfield. And the picture you see there is Jimmy, one of our pilots. And the reason I actually put this picture up there is to highlight the importance of occupational health. It really opened my eyes with this case. I was a young flight surgeon at the time, and we had to fly helicopters. We were flying from Amarillo, Texas to Tucson, Arizona, and had to stop in Las Cruces, New Mexico to get gas. And as we were hopping out of the aircraft, Jimmy's like, I can't hear. I can't hear anything. And being on the aircraft myself, and knowing we had a couple hours of flight left, that concerned me quite a bit personally. And so I said, Jimmy, let me take a look. Let me take a look in your ear. And I'm looking in there, and it doesn't look right. I'm like, oh my gosh, we didn't go over 10,000 feet. I'm not sure what's going on. It looks like you have a hemotympanum here. And then I looked a little closer, and I was like, wait, those edges are very symmetrical. And his earbud had actually come off and fallen in his ear. So a little bit of grabbed the tweezers, pulled it out. He could hear just fine. And the moral of the story is little things have huge impacts. So this earbud falling off, me being able to look in and pull it out, had a huge impact. Of the mission still was able to continue, and we were able to get our gas, fly from Las Cruces, and make it to Tucson timely. So it was it really did matter, and that's what we do in occupational health and with the on-sites. It's very little things that seem trivial, but they make massive impacts. Well, now I put on the suit and tie. I don't sit on airfields as often, and I get to talk to fine individuals as yourself. So at Marshfield, I chose Marshfield because of their mission in enriching lives. And what I think it means for occupational health to enrich the lives is really we enrich the lives of the workforce. That includes employers and employees. So we're here to serve the workforce. And our values, I want to skip down to the values, that patient-centered. I say it's on top for a reason, that this is ranked from most important down. Others will disagree with me, and within Marshfield, there's lots of debate around that. But in occupational health, patient-centered is a little bit different. Most clinicians, the patient is sitting in front of you. It's the injured employee or the sick person. But in occupational health, it's different. We have 3 patients, and this is what I teach to the system and to my colleagues and within the occupational health department. We have the injured worker or the worker that needs the service sitting in front of us, But we also have another patient, two other patients we don't see. It's the worker to the left and right that depend on that person. They either need to be on the line with them so they're not redlined, or knowing that the employee that is there can be trusted and is medically fit to do the position. Because a lot of these jobs, we depend on the man or woman to our left or right to get the job done. And the third is the employer, because the employer is the one that brings everyone together to meet that common need to improve our society as a whole. So what are we doing? Kind of touched on this already, the workman's compensation, the industrial athlete program, and then a little bit on COVID response. So the background within Wisconsin on the workman's compensation, I'm sure a lot of us are aware of this, but just to touch on it, the injured worker in workman's compensation gets to choose the provider. This makes it a little bit more difficult on our end in trying to take care of all your injured workers, whether you're API, Felker Brothers, etc. The employee gets to choose where they go. They can even choose a chiropractor if they want. They get first and second choices, as you're well aware. The first 3 days off work are uncompensated in Wisconsin. This is actually very helpful when we're educating our urgent cares and our emergency departments, because this is a way that we're able to let the physicians or the care providers. Oh, someone's. No. Are we getting feedback? No. Okay. This is how we let them know that they're taking someone off work has implications. One, for the employer, their DART rates, their MOD, how much workman's compensation increases based off of these kinds of taking people off work unnecessarily, which clinicians will listen to, but just to be frank, they care a little bit less about it. It takes some work on our end for them to understand that. But how it negatively impacts the patient sitting in front of them as clinicians or advocates for their patients. So it really helps us. And you take them off work, you're actually taking money out of their pockets. We want to take body parts off work, not people. The other ones that only a physician can make a causation determination in Wisconsin is what we've really been pushing, because we've noticed that sometimes nurse practitioners, PAs have been in the process and we haven't gotten the physician to make that causation, causing some issues with WKC-16s and administrative processes on the workman's compensation side. So we've really made great gains in that realm. And then causation is determined by a reasonable degree of medical probability. This one creates a lot of debate within providers, and it's not just internally with Marshfield Clinic providers, it's providers, occupational health providers nationally, or Wisconsin providers as a whole when you talk to Ascensions, Aspirus, Mayo, etc. So I actually want to read this to you verbatim, and this is where the causation piece becomes so frustrating and why you see so much variability in one provider on causation that you're like, how in the heck is that causation? And another provider that says, no, it's not, right? In what it says verbatim is, this is from, you have the website, the URL on the bottom, it's from DWD. And it's the question on the WKC-16B concerning causation and disability are to be answered to a reasonable degree of medical probability. The Workers' Compensation Act does not require 100% certainty. The standard is a reasonable degree of medical probability, meaning more likely than not, as opposed to speculation or a mere possibility. And so what does that mean? You hear it coming up to, it means you're 51% sure that the workplace caused the injury and that the injury caused the disability. But that would mean you were wrong 49% of the time. So providers don't like to use that verbiage. Then there's also providers that bring up different case laws saying, well, you know, and it was brought up to me, White versus Lyric said that 5 to 10% contribution would make a reasonable degree of probability, which I think is a misinterpretation, but that is where this comes from. And And the guidance leaves a lot of subjectivity to the provider themselves to make that determination. What we teach what I teach and at Marshfield Clinic Health System, and I always bring up to my colleagues, whether it's nationally or in the state, is we're scientists. We should not be making subjective decisions. We take the laws that are written by the state of Wisconsin for workmen's compensation and then apply the scientific approach to it. And so I really love the American Medical Association's Guide to Causation. I use this book all the time, and what it does is it promotes a 6-step approach for evaluating causation. One, you got to identify the evidence. What job is the employee doing? How many hammer swings are they taking? Was a work site evaluation done by an athletic trainer or a physical therapist to give us evidence of the job itself? And then once we have the evidence of the job itself, the next that would lead to the injury, right? So if you're working at a desk, you're typing, it's a sedentary job, and you're complaining of foot pain, well, does that really line up? That's what it means. Identify the evidence and the mechanism of injury makes sense with the injury they have. The second thing we do is we want to review and assess the available epidemiological evidence, and that is brought into this book. We have a lot more evidence for correlated relationships or causal relationships with medical conditions, with age, with those types of things, just because of the way that we do medical research. But there is also correlation in some studies with different kinds of workplace requirements. And so we try to take that all into effect. We want to obtain and assess the evidence of exposure that goes along with those worksite evaluations, or knowing what the worker actually did. Job descriptions are very helpful, but unfortunately, a lot of times what is happening is on the clinical side, when we're seeing them, we have the story of the injured employee, but not necessarily the story of the employer. When the IMEs are occurring, it's a little bit goes the other way. They have a lot more information from the employer and less from the employee. We want to, number 4, we want to consider other relevant factors. Is there something else going on contributing to this injury? Is there obesity going on? Is there a pre-existing condition, et cetera, et cetera? Step 5, we want to judge the validity of the testimony. Does it make sense? Has this person shown a pattern of workplace injuries, work comp, move to the next place, workplace injury, work comp, and bouncing around? So we want to judge the validity of the testimony. And then the last step is form conclusions about the work-relatedness of the disease in the person undergoing the evaluation. So we bring it down to a 6-step scientific process. This is just a recommendation in Wisconsin state law. None of this is required, but these are the arguments I bring up to my colleagues and what we teach here within Marshfield Clinic Health System for causation. Even within Marshfield, within our system, physicians are licensed under the state of Wisconsin, and so we can't direct them to do something that the law does not. So I've actually talked through a lot of this next slide. I'll just touch on a couple points here. One thing that we've done internally is we've hired our regional occupational health nurses. Their title is managers, but they really are working as liaisons with the employer. So they're in Marshfield. Amy Yurkovich is the regional nurse that is working with the employers, and that's helping shore up. If you had an employee come in, went to orthopedics and didn't get the return to work note, contact Amy at one point, and then we make sure that we get that return to work, and to shore up a lot of those little painful sticking points that we've had with workman's compensation and with getting services delivered to you. And it's been a great help to have these regional nurses. And as we find gaps in our systems, they see them first because you're contacting them and they're working in the boots on the ground, which elevate to Chad and myself, and we're able to, from a system and process level, start to fill those gaps. The urgent cares and emergency department staff have been taught on the occupational health basics. I've been going around quite a bit doing this presentation, and this presentation is really the take-home points are first aid treatment if possible, right? Don't just throw sutures in and use lidocaine, which is a prescription, if you can use steri strips for a superficial laceration and return them to work. Therefore, the employer doesn't get a 300A. And so we're doing a lot of education along that, which the urgent cares and emergency departments are actually very helpful for. We teach take the body part off work, not the person. We really say if you're going to the urgent care or the emergency department, worst case scenario, put them on sedentary work and get them and make the recommendation of a referral to occupational health to get a more specific restriction order. And we really want to get our providers out to work sites so they can see them in order to make very valid, reasonable work site restrictions. The nurses are also helping with this quite a bit because they have been to most of your work sites. And the causation piece is done by a physician. We've also made some changes in our drug screenings and educated them on those, taking a lot of that to our phlebotomists in our labs. All right. The industrial athlete program. I'm actually really excited about this program here, and it's one specific part of the program is I kind of really like, and that's the baseball card program. So what we've done here is industrial athlete program has been around for a while. We've reinvigorated it. The foundation of this is around the nationally recognized Work Well model. The athletic trainers, physical therapists, and individuals that are part of this program have been or are currently being trained in this model. The baseball card program really excites me though, because the intent of this is for a lot of times really within manufacturing or agriculture, some of those heavy type of jobs, we're doing pre-placement examinations, and the pre-placement examination has some lifting component to it, but not a lot. And when I was doing them, I felt that I didn't quite have enough information to be making good decisions and giving the data back to the employer that the employer needed to be able to put the person in the right positions at the right time. So this baseball card program, which is available there in Marshfield, the intent is to have an athletic trainer, physical therapist, someone trained in the Work Well model, come to your location and evaluate the work site and the different jobs, specific jobs, how many foot-pounds of pressure are required for this, how many upper extremity repetitive motions are occurring, how many times are they bending at the knees or the waist, et cetera, et cetera. That's the job site analysis. And then when we get those jobs set up, we can put them into categories and take the employee, the new hire, and put them on what is a BTE machine. BTE is a company name, BTE Technologies, but the BTE machine is really isometric, where you put pressure on a lever in different forms to see how much pounds per square inch you can produce. You can put a wheel on it, like you might see for a truck driver. Can you turn the wheel? How much force can you resist to turn those wheels, et cetera, et cetera. And so now we have objective data on your strength as a person, create a baseball card, and then when they go back to the employer, they can have the data of the job sites or the specific jobs that this employee would be good at or recommended for. And so then you know where they are for some of those heavier tasks. It also includes on-site musculoskeletal injury prevention, evaluation, treating. So an on-site athletic trainer is the recommendation I've always had for occupational health, where they come on and they're there treating your employees really like athletes, whether you needed some stretching before, after a shift, possible additions of Theraguns or ready sets, which are, icing and those types of things that we do with our athletes on a regular basis. Another component of this is the work hardening program. You do have to come into our clinics. You would be coming into Marshfield for that program, but that's to one, if you are part of the baseball program and someone just doesn't quite meet the needs for the job sites that you need them for with the VTE machine, we can help strengthen them up. Or if they're injured and we're returning them to work, we can get them back up to that peak performing condition. And then there's the education and the live presentations that they are able to do with your ergonomics, etc. Last I'll talk about is our COVID response. We still do have the seal of approval available, and I know that many of the employers there in Marshfield have opted for this, and Amy has been out to your sites, and she is looking at what is your risk for transmission or spread of the COVID virus, and then based on that, how many risk mitigation checks do you need in place to prevent or limit that transmission. Once you meet those, you do get a seal of approval sticker right from Marshfield Clinic. You can put on your front door, knowing that occupational health. And really the way it was designed, when Chad and I designed it, I said, when we design this program, I want it to be where I'm comfortable bringing my child into that facility. And so it's designed based with that concept in mind. So any company that has a seal of approval on the door, I am personally comfortable bringing my family inside that business. Granted, you have to let me in. So the COVID response email is also up and active. It's still there, and that's free of charge. You can see the bullet there on what the email address is, and this is where the return to work notes are happening, the questions, concerns are happening, COVID-19 testings for exposures are being ordered. If someone's medical high risk, we're letting you know, we're creating letters for that so that you may then put them in a position you're comfortable with. Never do we say that someone that's medical high risk, if they get COVID, should not be at work. That is not our place to say. We just say that this person is, place them as you feel is appropriate. The return to work notes have been very helpful. We do hundreds of these a day, and we try to do this because a lot of times our primary cares are just not quite comfortable with the return to work notes. So we're doing that through here. And then also, if all you need is a return to work note or a test, we don't want you having to come into the clinic, clinical visit, cost, more people inside of a building. So we want to do this all, streamline it for you. So this was set up in what works best for the employee and the employer. We've also maintained all on-site and in-clinic services for occupational health services throughout this pandemic. And there was a lot of pushback initially to pull back. And we just didn't believe that was appropriate, because the workers are there, the risks are still there other than the COVID transmission. And we need to continue to be there side by side with our partners, the employers and the employees. So we still today continue those services, and our clinics are opened for business. And the last slide, I just want to leave you with our contact information there, and want to give Chad a chance to add anything if he has anything to add, if I missed anything, and then open it up to questions. So go ahead, Chad. I think you have to, there you go, you're unmuted.
Yep, thank you, Dr. Cronrath. You did a great job, and I think you covered all of our key talking points and did a great job there. I don't really have anything. You covered everything that I had down to kind of discuss. So I see some communication coming through about, providing an example of what the seal of approval looks like. And so I'll send it out to the host here, and we'll give you an example of the window cling. It's probably a 3-inch circle that you can post, and we have a nice professional certificate that's signed by the business owner and Dr. Cronrath, our service line medical director. And so we'll be able to provide those. Looks like Dr. Cronrath might even be pulling one of them up for us, but we'll get those out to you so that you guys can see what those are. And if you're interested in it, the first step is just to reach out to Amy Yurkovich, and we'll come out on site and kind of walk through that with you. We like to say, there it is. We like to say somewhere around 2 to 4 hours for most businesses is the time we need from you. Depending on obviously how many different campuses and how large the plant factories are, that might expand out. But for most folks, it's somewhere under that 4-hour time frame. And so we'll turn it back over, Karen, to kind of open up any questions that have, and we can turn on the mics if we need. And
Absolutely. I thank you so much. I think, Chad, there's one more question or in the box, and it was from Samantha. Someone's mentioned, it says, you mentioned all on-site and in-clinic services. Are you doing PFTs and spirometry testing during COVID, that is?
Yep, I can take that. We are doing spirometry and PFTs within our system. You obviously need to be asymptomatic and not been told that you were an exposure, not under quarantine. And we do not require COVID testing prior to that either.
Okay, wonderful. If anyone else has any questions that are on the line right now, you can unmute yourselves if you would like to, or you can utilize the chat box. And with that, it appears you did such a fantastic job. We all can clap. And I appreciate all the time that you all are taking today for us. And we have recorded this session so that we'll be able to share this out. So we appreciate that. Dr. Conrath, you did a great job explaining things. Chad, you're right there for support. And then I know Michelle Kidder is on the line, who helped coordinate putting this all together. So appreciate Michelle's involvement with that too. There's Michelle, hello. And if anybody does have questions though, like I said, we'll share this slide out with our businesses and with also our HR group that we have here at the chamber, and that way, if there are any follow-up questions, we do have those that contact information here. Thank you all again for joining us today, and we hope you all have a happy Halloween and a great weekend.
Thank you so much.